Assalamu alaikum wa rahmatullah. Good evening. Welcome to our webinar, Medication Without Harm. On behalf of Saudi Patient Safety Center, I would like to thank all our audience. My name is Naf Sab'an. I will be the facilitator today. Special thanks to our speaker. Our speaker today, Dr. Thamir Alshammari. He is one of the figures in the medication safety in Saudi Arabia and in the world. Dr. Alshammari is the Associate Professor of Health Outcomes. He is Pharmacoepidemiology and Pharmacoeconomics Consultant, and he is a distinguished expert for Chinese National Drug Safety and Policy Center at Zaina, China. He is a senior researcher at Medication Safety Research Chair. He is a fellow with International Society of Pharmacovigilance. Dr. Alshammari is served as Dean of College of Pharmacy, University of Hail, and the National Pharmacovigilance and the Drug Safety Center at Saudi FDA. He is the chair of Saudi Higher National Pharmacovigilance and the Drug Safety Committee. Dr. Alshammari has over 100 publications in peer review journals, and he has invited to many national and international conferences and meetings. Welcome to Dr. Alshammari. Dr. Thamir, mic with you.
Thank you, Dr. Nof. Bismillah ar-Rahman ar-Rahim. As-salatu was-salam ala Rasulullah wa ala alihi wa sahbihi ajma'in. Welcome, everybody. For today's webinar, I would like to thank the Saudi Patient Safety Center for inviting me to discuss and to share with you one of the initiatives by the WHO, which is the Medication Without Harm. And I'm sure many of you have heard of this, if not already expert in this part. So what I'm going to talk today is what we need to do with our patients, especially in healthcare environments, when we talk about the using of polypharmacy for our medication, when we talk about the transition of care. So all these we're going to discuss, and I'll be happy to have any question from you or discuss or even comment. I'm sure that we have a lot of expert people in this group, so it's like more of discussion and sharing the experience together, not just lecturing. So my name is Thamir, and what I'm gonna talk today is only represent myself. That does not represent the Saudi Patient Safety Center or my employer or even the WHO itself, because I'm also working with the WHO as well. So it's all my own on my own part. So maybe majority of you have seen this map, and this map is a real fact. Unfortunately, many of us do not think a lot about this map before we have it. This map telling that every institution, every site, every location, every time, at one time we'll have a medication for us, for our families, for our police, for our friends. So, but at the same time, we're not really focusing a lot on this and the safety of these medication. We're focusing on safety of other things rather than things that we're taking inside our body. So this is really what we need to focus on and to think about the medication and the risk from the medication. We need them. They are very beneficial for us. Reduce and need to be mitigate for us as a patient or for our families. So why we need to focus on medication error themselves, and this because of the statistics and always based on number, and this number next to you in England, which is one of the developed countries, we have almost 250 million medication error occur, not during the all time of the UK of the England, but only in 1 year. We have almost 237 million medication error. And this is a huge number. And what's the problem is that 5.5 million of these errors are potentially affecting our patient and clinically significant harm. And this is really, it's really a huge number. Imagine in the UK or England itself, 1 in 6 people get harm from medication. This is a huge number. And the problem, it's with us as this part of the world. It's double when we talk about the low and middle income countries, especially when we talk about DALI or disability adjusted 5 years. And this because of the loss of the medication. This really need on the medication, Middle East or other the region that's close to us. I'll give you some of the example of real story, and these are real stories. And this you can find it in the website, put it down, the WHO. I'm sure some of you know this lady, this Betsy Lehman. She was one of the famous Boston Globe columnists. It's a journal in Boston, North America. Betsy was, she was only 39 years. She has 2 nice daughters. One of them an annual screening for breast cancer, and they found there's a small lump, and they decided to ask her if you want to take it now, or you can wait until we can do it annually. So they say that's fine. I can do the surgery, to the mastectomy. She went to the hospitals, in Boston, one of the well-known hospitals in Boston, and she gave her chemotherapy because they want to reduce the size of the lump in her breast. And they start to give her a cyclophosphamide chemotherapy before the surgery, which is for 4 days. She got the first dose, and she feels tired, and she told the nurse, "I'm tired from this drug." And the nurse told her, "That's fine. All the patients suffer from this because this is chemotherapy." So next day, she told the nurse this again. I feel I'm not okay. I have problem in my chest. So can I talk to the doctor? She said, this is expected. This is the second dose for you. But again, I will to the doctor and will concern and you'll be fine. The third day, she got the third dose. She was very sick. She was very tired, and told the doctor, "Doctor, I'm not feeling okay. I think this medicine is really tough on me. Can you do something?" The doctor told her that tomorrow the last dose, and you'll be fine. Then we'll do surgery. Then you will go home. When they gave her the fourth dose, unfortunately, she found Betsy died in her bed with age 39. And when they investigate the problem, they found that Betsy, instead of taking 1 gram cyclophosphamide, she was taking 4 grams cyclophosphamide because of the mistake. And this is a quadruple the dose. This is chemotherapy. This is toxic, and this is led her to death. She was diagnosed later on with cardiotoxicity, and this is the pain she has in her heart. So no one was checking her medication. There was no medication reconciliation. There was no medical review. There were no one asking. The nurse and the physician or pharmacist, they were not talking to each other. So these preventable medication could be prevented if they were listening to the patient. The other story, this man, his name is Amin, is one of the East Asia countries. He has hypertension, diabetes, and he went to the hospital to ER because they have high elevated blood pressure and elevated blood glucose. And they go to ER, they treated him, and they sent him back to his primary care doctor. But they noticed he has elevated uric acid. And they were like asking why his primary doctor did not give him allopurinol so they can treat it. So the physician at the hospital started to give him allopurinol, and the patient take the drug. And within a few days, second days, he developed Stephen-Johnson syndrome. And later he developed TEN, which is tumor epidermal necrosis. And unfortunately, within 3 days, he died because of allergic. When they go back, they found that those people, they should not take some of the medication, including allopurinol, because they have a gene they have mutation and they have like allergic to this drug. And the primary care physician, he knows that, but unfortunately, without asking, without checking, without communication, without inappropriate prescribing, this lead to a preventable medication early to the death. The last one I'm going to talk about and go to the one at TVU. But if you need more stories, even if you want to present them, please check out this website. We have like almost 15 or 20 stories, and all these are real stories. Dora, her daughter found her like she developed some tremors, and she took her mother to the hospital. She was fine, but only the tremor. And when her daughter was educated, when I believe she was a nurse, and she took the physician and told her, "Didn't you think this tremor was due to my mother a lot of medication?" He said, "Might be." And she told him, "Might be drug-induced Parkinson's." Yeah, they diagnosed it with Parkinson's, and she said, "Might this be drug-induced Parkinson's?" He said, "Might be, but we cannot know until we take off all the medication or take out all the medication, and then we see." So the physician told her, "This is a little bit dangerous." She was a lot of like 10 or 15 medication. So what the daughter did, she said, do it from herself, because she saw her mother have a really significant tremor in her. She cannot even sit down or even sleep. So she took out all her medication for like a few days, and her mother, guess what? She back to her normal. She stopped the tremor, and the tremor was due to the drug inappropriate. And this is when a polypharmacy was prescribed to the patient. This is what will happen. So again, please, when you deal with your patient, always think of these points. I'm going to talk about some of them during my presentation. So again, based on that, the WHO started in 2016. They have a third initiative, because we have the first and second, we have the third initiative challenge, which was the medication without harm. So let me ask you, give me a break from my voice. When the third WHO Global Patient Safety Challenge, medication without harm, was launched? Was it launched in 2020, 2019, 2018, and 2017? And now the poll will pop up to you, and please answer to this question. Is it 2020, 2019, 2018, or 2017 was the year when the launch? So you can select one of these options next to you. So let's give them 15 seconds until the answer. If you have problem in answering this poll, please let us know. Okay, I don't know if they can answer the poll, but we can close the poll now. Okay. So it's actually was launched in 2017 in Germany. We're going to talk about this in the few slides. So the third WHO Global Patient Safety Challenge was issued because of to address this bigger problem with the medication, with the medication error, because in addition to what I mentioned before, it's burden on our patient, and it's burden on the cost of the government. It's cost almost $42 billion annually, which is a huge amount of the money that we could prevent them as healthcare professional. It's also burden the patient and the healthcare system. It's lead to hospitalization, also prolonged hospitalization, harm to our patient, and also is associated with the death and also a lot of disabilities. So in 2017 in Germany, the WHO, the second global, it was launched as the second global Ministerial Patient Safety Summit in March 2017, with the purpose is to reduce the severe preventable medication error by 50% in the next 5 years. So when you say 50%, it's really depend on your country. So we know that countries are different in the rate of the medication error. So, but based on your number and your baseline, you can assess what 50% for you, because 50%, for example, in Saudi Arabia will be different. Egypt will be different, for example, Iraq or Japan or the US or even the UK. So it's depend on that. And the responsible office within the WHO at the Patient Safety Office and Quality Improvement Unit. And if you need any help, you could directly contact them. And this is for the countries. So the objective of this initiative is to have multiple rules to assess this problem and how big the problem is. Also to create a framework for action for different stakeholders to be guiding for them, framework for the patient, healthcare professional, and even to the countries for monitoring and evaluation state. Also to have different guidelines, material, technology, and tools, and I'm going to talk about 3 of them later, and engage more stakeholder to increase the awareness of medication error. And the most part of this objective is to empower our patient, families, and to be actively involved in medication error. As I mentioned before, remember this daughter, because she's really involved in this area of health and safety, she understands that why her mother might have the drug problem. But if someone else does not understand, this is the mother might lead to like more life-threatening situation and might die because of the Parkinson. So that's why we really need to engage our patients and families in that. So when we work together, I mean, the WHO themselves, as with the different people, the committees, they said we have a lot of problem in the medication safety, but we need to focus on what is the priority for us. So they defined 3 key areas based on what is the most visible, what is the most urgent, and we need to face as public problem. And the 3 key areas, one of the technical documents that we were working on there. The first one is high-risk medication or high-risk situation, the polypharmacy problem in medication safety, and also the transition of care in medication safety. So they have different groups, different committees were working in that. Some of them, they're like people working in different committee. This one of the committee that we were working, actually we did it in Geneva. We were working from like our places, our countries, and also we gather and meet in the WHO office to discuss and to finalize this document. So what do you mean by high-risk medication or high-alert medication? And this definition, this is by WHO. But again, you could also have your own definition. It really depends on your situation in your country. So the high-risk medication, drug that bear heightened risk of causing significant patient harm when they are used in error. So this medication, when an error are associated with this medication, usually will lead to a significant devastating issue to our patient. However, mistake may or may not be more common with medication, not necessarily to be common with this high-risk medication, but when an error happens, usually will lead to really a devastating harm to our patient. So that's why we really need to focus on the medication use process. We talk about prescribing, dispensing, monitoring, transcribing, and this type of medication. We need to focus on all medication, but we need to give more focus, more attention to high alert medication. Like when you talk about look-alike, sound-alike, naming this might lead to a problem associated with this medication, or the package when they have the similar package. So again, we need to focus on different medication use process. And this figure, one of the figure that I recommend that always look at it, because this figure is telling you that majority of medication error and also the adverse drug events are preventable. Almost 75%, or sometimes at least up to 90% are preventable. So we are lucky it's just a few of these adverse drug events are you cannot prevent. And this is mainly due to the mechanism of action. For example, we talk about anticholinergic medication, like we know that they're associated with dry mouth, because this is dependent on the mechanism. You cannot change it. Okay. However, sometimes you cannot try to help the patient of giving supplement, for example. But some of the medication, so we'll talk about drug-drug interaction, talk about medication that can be taken in a specific situation. For example, the medication that cause a problem to the stomach, you can take it after the food, if not interacting with the food. So this is a really good that we have a lot of medication can be prevented during the process of medication use. So next question is insulin. Insulin is drug used for diabetes. Is this considered as a high alert medication? True, false, or I don't know. So let me, what do you think? Is insulin a high alert medication? Please select one of them so to talk about it. I'll give you 10 seconds, 15 seconds. Okay. Okay. Can I see the poll results? So, oh, sorry. Can I get back, please? I thought like almost 68% of people say yes, which is, this is a good answer. So yes, insulin actually, this is the list of some of the high alert medication that we are using as a list. Again, this is some, but you can have your own, it depends on your situation. So we have what we call anti-affective drug like amphotericin and also amino glycosides, potassium, especially in the injectable form. All types of insulin, they are considered a high alert medication because any medication error associated with insulin could lead to really a devastating harm to our patient. Narcotic, of course, and we know the problem with opioid epidemic. Chemotherapeutic agent, definitely, heparin and anticoagulant, even the new oral anticoagulant and other medication that affect our patient. So this is, we call it a pinch, so you can just remind, so a pinch is the first letter from each one. But again, some of the medication that's not in the list, they might be also higher medication. It depends on your situation. Okay, so this keep in your mind. So we have different factors that influence these high alert medication or high risk situation. And by the way, when you say high risk situation, it's not only including the high alert medication, it's also including the high risk situation like elderly people, pregnant women, and also children, because these also need to look at them and check on them. So I have different factors. Medication factors could influence the high alert medication, high risk situation, provider and patient factor, and system factor. So we'll talk about medication factor. I'll just give you an example so you can understand it. So for example, as insulin, we know that abbreviation are prohibited in most of the medication, and especially in high alert medication, insulin, because when you use the abbreviation, it might be lead to mistaken. And we know that when you use international unit as IU, could be read as different as number. It could have like double dose of the patient. So there is you should not use any abbreviation. Also, when you use a specific syringe for the patient, it should be well titrated. And unfortunately, some hospitals, they have only one size syringe, the big one. So if you want to dispense the syringe, the patient, large syringe that's even if titrated, you might not get the exact dose. And if there are changes, small changes in the unit of the insulin, it might lead to more like hypoglycemia or even sometimes hyperglycemia. And in case of insulin, it needs to be prescribed by brand name. This is different than other medication, which should be by generic name, but this needs to be brand name because all are insulin, but they're different time. And now with the pen devices, they also need to be specified by the name. Especially when we talk about the different look-alike and sound-alike, we really need to focus on exact name. The last point, which is as always mentioned, we need to engage our patient, engage them, educate them, spend more time, because this will be most cost effective for you. Okay, and this is some strategies that are used for reduce the high risk medication. I'm not going to go over all of these things, but just put them so you can understand. We have them for your reference. So first one is standardization. When you have standard, for example, doses, that you should not have big variation in the doses to limit the mistake in the dose. Also, when you use the failure mode effective analysis and self-assessment, which is FEMIA, we have two concepts in the safety, risk management. Let's talk it in a specific. One is FEMIA and one is RCA, which is root cause analysis. Root cause analysis, you did it when you have the problem occur and you need to know what the problem, why it happened. FEMIA, when you proactively identify the risk, okay, so this patient, we have a lot of patients taking insulin, so we might have this risk. We need to prevent it from the beginning. We need to prescribe by brand name. We need to separate it from different than other. We need to have a specific refrigerator for insulin. So you proactively work to identify the risk. Also, we have like, you either limit the access, so only specific patient take this medication. Again, this is called risk management plan. Also, or like to be limited access to be prescribed by a specific prescriber, consultant, or a specific area. Also, sometimes you use constraint and barrier. That's the best example of the child-resistant bottle, so you don't want the children to take these medications. This is just an example to help you to reduce that. When you go to the second one, which is provider and patient care, and also this is one of the figures that always keep it in next to you, because you need to ask yourself before prescribing, does this patient really need this drug or not? What if I don't give this drug to the patient? What happened to the patient? And when you prescribe, you need to check if this is the right patient, if this is the right medicine, is it the right dose? Just do that with each patient. So this is at the prescribing level. When you go to the dispensing and storage, similar question, is this the right patient, right dose, right duration, and also with administration. And this is very important. You need to check this drug is really for this patient or not. And this one, I put it in this square because there's a need to work as a multidisciplinary team between physician, pharmacists, nurses with the patient. We need to include the patient. And this is a good example for medication reconciliation. All this team, they need to work together for our patient. Also, you don't want to have over-prescribing medication or under-prescribing. So you don't want to say, okay, I don't want to give this patient many medication, but the patient already needs the drug for hypertension. Okay, so also keep this one, or misprescribing or giving different or wrong medication. You need to think about other factors. Polypharmacy, does the patient have many medication? Multimorbidity, is the patient has different diseases or multiple diseases, and if these diseases are high risk medicinal condition or not. So that's why we need to have strategy to reduce the medication error related to the provider and patient. Whatever the patient's specialty is, consultant, cardiologist, infectious disease, they need to get education and training in patient safety, both healthcare professional and patients. So please make sure that all the people working in your institution are really trained on the safety. And this is one of the good things that's by the Saudi Patient Safety Center, that's continuous have training program, because we need that. No one are really expert that's in multiple areas. So everyone is really need to get training in the patient safety. And we need to have like more focus on medication reconciliation. I'm not going to talk about now, talk about it later in the next few slides. And the WHO, they did a great, what they call the 5 moments for medication safety. This is for both healthcare professional as well as the patient. And you can find in different languages. It's in English, in Arabic, in French, and other languages. What is 5 moments? It just ask yourself as a patient or even the healthcare professional a question when you start the medication. What is the drug? How it's work? What are the side effects? So this is a question the patient need to ask, and also healthcare professional need to ask. And when taking the medication, they should ask, what is the best way to take the medication? When can I take it? Can I take it at night, at morning? Can I take with food, without food? What about other medication, like a drug interaction? And also, when the physician decides to add a new medication, does this patient really need this drug? Why he needs this drug? What's the justification? What's the drug interaction with this drug, or even the disease interaction? And also, the fourth step, they need to review the medication. Always make sure the patient know what they are taking, have the list of these medication. And also, when they decide to stop medication, do I have to stop my medication and why? Do I have to take the drug for long, especially when we talk about the chronic diseases patient? So this 5 moment, if it's me, I would love to have this 5 moment in each hospital, in each health institution, to read them from time to time to just understand why we are taking our medication. Third point, which is the system, factor, work environment. Unfortunately, as healthcare professionals, we work a lot. We have a heavy work load, especially in a specific area. I'll give you the intensive care unit as an example. When it's like busy area, when you don't have follow-up with your patient, either in like an ICU or even during the ward or even outpatient visit, then you don't know what happened to your patient. If you just left your patient 6 months and you know nothing. And unfortunately now, for people with chronic diseases, sometimes like 6 months or 1 year, then the physician or the hospital themselves, they don't know anything about their patient. And this is one of the system problem. Also, some of the hospitals, they have no technology to help them. No, the prescribing, computer prescribing. They don't have dispensing machines. So all these things, technology use is really important to have. However, don't have also too much technology, because you really need to follow up with the system that you have, because technology made a mistake even more than human. And this report found that in 2020, one of the top 10 health technology problem is the medication error due to dose discrepancy in electronic health records. So again, even if you have a system you need to follow up, you still need healthcare professional for that. So my third question to you, and I would like to answer all of you, and I would like Turkey to keep the poll a little bit more. How many drugs that are referred to as a polypharmacy? When I say polypharmacy, do you mean 4 drugs or more, or 5 drugs or more, or 6 drugs or more, or 7 drugs or more? What do you think? Give them 15 seconds so everyone can answer. And again, please, if you have any question, if you have any comment, if you want to say something, you have the chat, you can answer. Okay, can I have the answers? Okay, so I see like majority of you mentioned number 4, which is A. So this is a little bit a tricky question, and I meant to have it. So I will tell you why. Polypharmacy is concurrent use of multiple medications. So if I have multiple medication, it's really mean polypharmacy. So although there is no standard definition, and this is very important, polypharmacy is often defined as routine use of 5 or more medication. So for those who mentioned 4, this is not a wrong answer. It might be also a right answer, but this is what the 46% of the study, when they evaluate polypharmacy, they considered 5. But again, it depends on the place. Sometimes 4 medication in your place is really considered as polypharmacy, but as a definition, usually they used to consider as a 5 medication. So this is also not only taking the medication themselves, but also including the over-the-counter medication, traditional medication, herbal, and the goal in this is to reduce the inappropriate polypharmacy. Sometimes what we call appropriate polypharmacy, that we really need them, but the goal is to reduce the inappropriate when you have irrational prescribing of 2 medicine for our patient. So what do you mean by inappropriate? So when one or more medicine are prescribed that are not or no need that the patient take it. Why? Because there is no evidence-based indication that the patient need it. For example, some people, they believe some of the cough medicine, there is no evidence they're really good for cough. So there's no need to use medication. Or the dose is really high, that's no need to get it high. So for example, when you have like hypertensive medication, 20 milligram might be good. So I give to 50 milligram, especially the maximum dose is 40 milligram. So this is also, we need to check them. And this is where the medication reconciliation occur in this place. When our medicine fails to achieve therapeutic objectives, so you give the drug, and you know this is the patient is, or sometimes you don't know, the patient to take a drug and the patient is not improving. And this is considered inappropriate polypharmacy. One or more combination of several medicine cause ADR or associated with adverse drug reaction, or patient at high risk of ADR. And unfortunately, some medication cause ADR, and healthcare professionals, they don't know about it and they don't do anything about it. It's really important to think about it. So the patient is not willing or able to take one or more medicine as intended. And this is also, you need to consider your patient, or cannot, because some patients, they cannot take more than 3 or 4 medications. So you need to treat them differently in this situation. So this is what we call it by inappropriate. However, as I mentioned before, sometimes we really need to give patient polypharmacy to treat them. And unfortunately, in this, again, part of the world, we have patients with hypertension, diabetes, and different diseases. That's, like, for example, to prevent myocardial infarction, you need you need to give them beta blocker, statin, antiplatelet, and ACE inhibitor, because you really, these the medication as guideline need to treat it. But make sure you give the right beta blocker, make sure the right dose of a statin and antiplatelet, and make sure to continuous monitor your patient, because you might need to reduce the dose or at least reduce one of the medication. Because also there are different risk factors for polypharmacy. We'll talk about the patient-related, elderly people, patient with cognitive impairment, patient with disability, anti-frailty, especially in elderly people. Also, the other problem with lacking of primary care physician to monitor the patient if they are still need this medication or not. Patients with mental health, Alzheimer, people who forget or dementia, people with multiple chronic diseases that they need for polypharmacy, or people who are residing in the long-term care facility, healthcare nursing home, that's associated with the risk factor for harm to the patient. Also, the healthcare system, we don't have good database recording. There is poor transition of care. We have a lot of prescribing, and we use of automated refill systems that without monitoring our patient. So all these factors, consider them when you're treating your patient. Also, there's a big and a huge impact economically on our patient. So when we have polypharmacy, mismanaged polypharmacy, it's contribute to 4% of the total avoidable cost. So imagine you could avoid billion and billion of US dollar of that. So a total 18 billion US dollar that can be avoided if we apply the appropriate polypharmacy management. And one of the studies found that when you do a medication review, there's almost 16% fewer hospital visits for a patient and 47% few visits to emergency department. So you talk about two things, a lot of less burden on our patient and a lot of less burden as a cost. And this is really important just to apply simple technique in patient safety or medication related error. And they found a study that when patients receiving 5 or more medication, they have the chance to have almost one-third or 30% of medication error. This is a really huge number of percent. Patient of 10% of almost 50% get medication error. And this have a lot of implication, talk about the increase of risk medication error, drug-drug interaction, suboptimal patient adherence, and also drug quality, reduced quality of life. And in care home or nursing home, they found that 40% of prescription for nursing home, they are not appropriate for this patient. Imagine almost 50%, half of them, they don't need this medication. And the UK, People in home care, they have taken 8 medication a day, and almost over 75%, they have 1 or more medication error, almost 3/4 of them. And this is a huge number. Again, when you talk about performance, think about OTC. This is something that to consider. Traditional and complementary medicine, but vitamin, minerals, and herbal medication. And in herbal medication, I think last week, we got this from the Saudi FDA. We have what the substance called murra, or mir in English, or in Greek. This is used as commonly in this area, and I believe other area in the Arab countries. It's used for different uses, for cough, for septic. But the problem with this medication has a lot of these substance, or these plant herbs, is have a lot of drug interaction. So this is what you need to focus on. Unfortunately, many people, even healthcare professionals, they don't think about these points. So move now to the transition of care, which is really important to understand what do you mean by transition of care. That's why I'm asking you the next question. Mr. Turkey put the poll. Transition of care is one of the processes in healthcare. What does it mean? What do you mean by transition of care? I'll give you 20 seconds so you can read the answers. Please answer this question. Okay. So can I see the answer? Because unfortunately, many healthcare professionals, they don't really understand. What do you mean by transition of care? Is it like only the hospitals? Or is it like outside the hospitals? Or what is like any place in the hospitals? Or is it related to the care of health? So actually, it's the last one. Any patient getting any type of care within the hospitals, moving from the ICU to the ward to the outpatient, to go to the home, when the patient talking to the physician or the pharmacist, these all considered as transition of care, because you are still getting the care to the patient. So the transition of care as a definition, at the various point where a patient moves, so we're moving, or return from a particular physical location, so a place could be a hospital, could be a clinic, or also make a contact with healthcare professional for the purpose of receiving healthcare. Even sometime when you call, this is considered transition care. Here, for example, in Saudi Arabia, we have the hotline called 937. You could call the Ministry of Health people, have consultation. You can ask them, you get the information. This is considered also transition of care. So it's not physical, or also whenever you get the care, this is transition of care. Okay, and this is one of the figures was also very nice one, and this again talk about later on medication reconciliation. You need to get communication, different work when you go to within the hospital, even diagnosis, even getting the lab, getting the medication, getting to talk with the other patient. All these you really need to think about it. And this is also a good example of how to apply the reviewing or medical review for your patient. So this is the patient with his medication, and when they get the hospital, the ER, check the medication, make sure these medications same as in the record. And during the hospital stay, you need to check every day, are these medication really good for our patient or not, until getting discharged, and make sure this medication compare with this medication to make sure what is the justifications, or what are the justifications of changing the medication or continuing the medication. Again, unfortunately, not many healthcare professionals are applying that. And when you go as a statistic in different places, you talk about community, hospital, transfer within the hospital, discharge, you will always talk about 57 or 98%, 80%, 62%, or even 97% of discrepancy of the medication. That's really a huge problem. And you cannot imagine until you see it yourself. When you see the patient have totally different medication, and you don't know why these medications have been changed. And there's again, just to tell you what the transition of care, it's actually everywhere whenever get the care. So the last part here, which is I'll go quickly to talk about it, which is the improved medication safety and transition of care. You have different ways to do it, like you engage patient with family and caregiver. Patient health medication list, you could like every patient should have a list of medication. They can like give them to the care provider. Support around the discharge. So during the discharge from the hospital, you need to make sure you do all the necessary information or getting the necessary information to make sure this patient is really getting the right medication. And on that, post-discharge patient found that 1/5 of current use prescription medicine had not been recorded. So imagine 1 in 5, almost 20% of the medication that be recorded during the hospitalization. That means he left from the hospital with totally different medication. Is it due to because it's not registered or due to different medication? We don't know. Okay, but this is a problem. Less than half of medication use has been registered in patient discharge letter only, which is less than 50%. So when the patient come back to the hospital for the like appointment, like 50% of his or her medication is not there. So there's discrepancy and really a big problem, especially when we increase number of medication. So in addition to the problem of patient factors and also the leadership in the hospital, that some of them, they don't really believe in patient safety, and you really need to change this to them. And always give them the numbers so they can believe you. So when a patient move across care setting, medication reconciliation is really considered important. As I mentioned to you, you need to follow up with our patient. We need to make sure that the patient is really taking the right medication. And a lot of study that hospital-based medication reconciliation practice showed a consistent reduction in medication discrepancy. And this is one of the area, again, this part of the work, we need to assess this as by research, the impact of medication reconciliation in our patient. So the formal process in medication reconciliation, when a healthcare professional partner with a patient to ensure an accurate and complete medication information transfer at each care level. And I put it in the bold, healthcare professional. It's not a pharmacist's job, because a lot of people, they believe this is a pharmacist's job. It's actually the main part of it is the pharmacist with the patient, but this is also job of all healthcare professionals, physicians, pharmacists, nurses, and other, even the radiology people, respiratory therapists, and other specialty, they should be involved in medication reconciliation. And this is one of the figure is really important that you need to follow. Appropriate prescribing, the risk assessment, the benefit and risk. You need to review all the medication to make sure when I dispense, I really dispense the right medication to our patient at each level. We need to have a communication. Unfortunately, this is one of the weaknesses that we have in all healthcare profession. Not talk about this region, and everywhere in the world. Communication is one of the concern, one of the issue that we have. And we need to do medication reconciliation at each care of transition. At each place, we need to do medication reconciliation. So what's the purpose? Is to optimize the medicine use and improve. When you apply medication reconciliation, you will make sure this medication is really the what intended to be used for our patients. So at the end, it will detect drug-related problem. Okay, so it's the purpose to improve appropriate medication, reduce harm, and improve outcome. It's really essential to do a lot of medical review to our patient. So this is, again, this is why I put it to you to just follow up when you need to do a step-by-step review of medication. And this is actually applied by most of the hospital. And this actually was taken from the practice in Scotland, in the UK. So first, just to go quickly, what's the aim of this medication? So we need to know the diagnosis to the patient, if this patient needs a drug or not. You can give the example of thyroxine, and etc. And it'll also follow up of the effectiveness. We need to monitor the medication of these are effective or not. Are these safe or not? Is it cost effective? And this is one of the things that's mainly been done in countries like Australia, the UK, that people focus on cost of their medication, if it's cost or not. And this we need to focus on that as well, and patient-centeredness. And we need to focus or we involve our patient in all actually therapeutic area that we need to focus on. And it's also in the guidelines. This is International Commission, Joint Commission International, to focus on the medication reconciliation. And here, for example, Saudi Arabia, we have what's called SIBAHI. It's also have one of the criteria to make sure that medication reconciliation is being conducted in the part. And this is one of the questions I want to share with you. If you want to make sure, what is the percentage in your institution that they are applying the medication reconciliation? So you just take the number of eligible patients receiving medication reconciliation, how many of them, and divide by the number of eligible admitted patients, and then you will know your percent, if you're doing well or not. So remember this figures, this map. Again, there's a lot of documents at the WHO website. As a member of the WHO, I also recommend that you go there, you read them, a lot of things that you will learn from. So the last two questions. When is the World Patient Safety Day? Is it in 17 September, 22nd September, or 17 November, or 25th November? Please, can you have the poll so we can answer? You have 10 seconds, so we can go to the next question. Okay, so can I have the poll of the answer, Mr. Turkey? Check the chat. Okay, so the World Patient Safety Day is 17th September, which is started in 2019. That's they celebrated the Patient Safety Day. So every year there's a theme of the Patient Safety Day. So what this year, 2022 World Patient Safety Day theme? Is it medication safety, mother and children safety, surgery safety, or elderly safety? So okay, so we can close the poll. You can see the answer. Okay, so this year will be focused on medication safety. So if you are planning on 17th September, please prepare from now so you can have awareness, people, about the importance of medication safety worldwide. Okay, so in summary, medication safety is very dynamic and growing fast discipline. But the problem is polypharmacy is continuous concern and really need to be addressed in different level and different stakeholder, and also focus the transition of care. Unfortunately, is not getting attention by different stakeholders. Not many healthcare professionals, not many stakeholders, especially the leaders, are focusing on this. That's why we need to work more in these two areas, polypharmacy and transition of care. And always speak up for your patient. Always act the patient safety advocate. We always look at your patient as one of your family. So this is my contact. Please, if you have a question, even after that, feel free to email me, or you can find me on Twitter. I would like to thank the Saudi Patient Safety Center and the WHO Collaborating Center on Patient Safety Policy and Strategies for inviting me. I'll be happy to get any question if anyone has a question. Thank you so much.
Thank you, Dr. Thamir, for your amazing presentation. And now I can, dear participant, kindly post your question in the Q&A icons. So Dr. Thamir can answer you. Dr. Thamir, let me start with the first question. What is your advice to spread 5 moments for medication safety for a patient And do you have a strategy for educate healthcare providers on how to educate the patient effectively? Thank you.
Thank you so much. This is a very important question. And as I always mention, we need to have the 5 moment to be delivered to our patient. For example, when I go to the hospitals, I don't see banners or I don't see anything related to the 5 moment. We need to disseminate this to the hospital. I don't see them, for example, in the community pharmacy, which is the majority of the patient or general people go to the community pharmacy. We need to have a campaign for this, continuous campaign, not 1 day, 2 days, or 3 days. We need to do it like annually. We need to do it in the media. We need to do it in the social media. Unfortunately, we're not using social media for patients. We're using social media for other things, but not using them for our patient. So this is a very important to disseminate in all means that we can disseminate the 5 moment. First, we need also it's already translated in Arabic. So we need to send the Arabic to our people who speak in Arabic. We need to send a different language for those who speak their language. We need to have it in the clinics, in the hospitals. So this is a very important part. We need collaboration between different institutions. So the Patient Safety Center, Saudi FDA, Saudi Public Health, the Ministry of Health, all these need to work together because because I don't see this, I'm not talking Saudi Arabia, I'm talking in general, but I'm just giving an example. We need to see this by different places. So for educating healthcare professionals, yes, first, we need to think more about the curriculum of the university and colleges to teach the healthcare professional, because they've got to finish, they're going to practice, they're going to prescribe or dispense or monitor. So they need to teach these things. Unfortunately, these are not being taught enough. I did a study to assess all the health colleges, and the patient safety is only taught in like 1 or 2 universities, for example, in the Middle East. So imagine, or in Arab countries in specific, 22 countries, they only 2 universities are teaching the patient safety, and this is really not good. So this is one of the things that we need to focus on in the teaching of the healthcare. We need to continuously train them, and thank you for the question. No.
I have another question, Doctor. For patient on polypharmacy, what is the maximum acceptable numbers of medication for a patient?
So I cannot give you an answer what is the number that the patient will be maximum, but you need to stop and see this medication, what the patient has as disease. Does the patient need to take all this medication? The question is, does the patient need to take all this medication forever? Or he or she might take some of them like for 1 week or 2 weeks or a month and then stop. Or even if the dose of this medication is right or not, if it's appropriate for this patient or not. Because some of them, I can't give you a lot of examples, but again, for the sake of the time, but there's no specific number, but the main point is to check if these medications are really needed by this patient. Are these doses are really right or not? Are these being taken in the right, as mentioned by the pharmacist or physician, or not? So this is what we need to do as healthcare professionals. Any drug, like any patient taking more than 4 or 5 medication, you need to check this information.
Thank you, Dr. Thamir. If you allow me for the last question, what is the best practice to apply medication reconciliation, and is it should done by nurse or doctor?
The best practice is to have interprofessional practice, meaning healthcare professionals, they need to go together. You cannot do it only by physician or nurse or pharmacist. If only will be based on one profession, this won't work in any institution. I know some institution has like some limitation, but this is work. This is a teamwork. It's not 1 or 2 profession work. So nurses alone not enough, physician alone not enough, pharmacists alone not enough. So we need pharmacist, physician, nurse work together for the patient. And some of the hospitals that I know, they have team for medication reconciliation that consists of nurse, pharmacist, and physician to make sure these patients, and they really is working well. If, for example, you don't have, you need to do your best at least to invite a group of people to work together. But one profession is not enough.
Okay, thank you, Dr. Thamir. At the end, on behalf of the Saudi Patient Safety Center, I would like to thank you so much for your amazing presentation, and I would like to thank for all our audience for their active participation. Thank you, and see you soon, inshallah. Thank you, Dr. Thamir.
Assalamu alaikum.